Good morning, everybody. My name is Craig Rodriguez. I'm a third-year internal medicine resident at the University of Toronto. I've been working closely with Dr. Jacob Udell, who's a staff cardiologist affiliated with the University of Health Network, to better understand the way routine health data can be used to help support cardiovascular clinical trials. Thank you for inviting me to create this presentation for the Health Data Research Network Canada National Training Program for Pragmatic Trials. So I'll go ahead and get started here. There are several objectives for this presentation today. The first being able to identify limitations in traditional randomized control trial methodology. The second being listing some benefits of actually integrating routine health data into randomized control trials, and I'll get into the definition of routine health data as well. And the third being to further gain a better understanding of the literature assessing the use of routine health data in randomized control trials. Randomized control trials are currently the gold standard for assessment of healthcare interventions. They are extremely important for evidence-based medicine and clinical decision-making. The randomization element of these trials helps us account for confounders and selection bias. Confounders include elements that we're able to see and identify, but also elements that we're unable to see too. The use of clinical endpoint committees is a hallmark aspect of what these randomized control trials are and how they operate. There are some limitations for randomized control trials, and 35 years after the first simple clinical outcome study for cardiovascular disease, we can continue to see a trend in how randomized control trials are operating. They're growing in complexity, size, and cost. And a major contributing factor to the time and cost of these randomized control trials includes their dependence on clinical endpoint committees. So what are these? Clinical endpoint committees are groups of experts who manually gather information through heterogeneous sources of, patient reports, telephone conversations, or various charts. And they're able to review these findings to classify the event as a clinical outcome or not. There are some disadvantages associated with randomized controlled trials currently, which include the cost and time associated with facilitating this process of this committee, the ongoing time it takes to actually recruit patients to these studies, and lastly, the actual duration of follow-up, as many of these trials are shortened to approximately 3 to 5 years worth of follow-up. So now enter routine health data. So what is routine health data? This is data without a specific prior research question that was developed for the actual collection of this information. So these forms and examples are actually embedded in our society, in our healthcare environment. And some examples that I can think of include administrative claims databases. So for example, OHIP, disease registries, and lastly, epidemiologic surveillance systems as well. A really good example, and I would say a landmark example of how routine health data has been used in trials includes the TASTE trial. So the TASTE trial is an acronym that stands for thrombus aspiration and ST elevation myocardial infarction in Scandinavia. This trial is actually nested within the Swedish coronary angiograph and angioplasty registry, as well as the Swede Heart database, which is an acronym that stands for Swedish Web System for Enhancement and Development of Evidence-Based Care in Heart Disease, evaluated according to recommended therapies. This database was established in approximately 2009 as an interactive dynamic health data system and platform through the merging of actually 4 separate national databases. So these include hospitalization databases, drug prescription databases, and lastly, vital status administrative health databases. The trial employed an established routine health data framework involving the periodic evaluation of outcomes concurrently recorded within linked administrative health databases. And after doing this, they were able to recruit a large representative population and complete follow-up with minimal cost and human resources. So just to review, and especially from this example of the TASTE trial, There are clear benefits associated with routine health data and its incorporation into registry clinical trials. The first being the reduction in trial costs during participant recruitment as well as follow-up. The ability to actually increase sample size because you can find various participants from these databases who could be eligible for your trial, instead of starting from scratch or trying to kind of cold call these individuals, for example. And then number three, enabling a greater number in total of large definitive trials to efficiently aggregate information and assess on a long-term basis. There are some questions that come up when we think about routine health data as possibly one of the next disruptive forces of healthcare innovation. The first being, is routine health data at high enough quality? A lot of these databases are run, for example, by administrative staff who are caretaking these databases without the sole intention of creating this information for research. And this can result in certain elements of miscalcification, for example, or incompletedness from a data perspective. And the question is whether these sources of misclassification would actually impact the quality of research that we would create from using these registries in future trials. So to answer some of these questions directly, enter our published paper, actually titled Accuracy of Cardiovascular Trial Outcome Ascertainment and Treatment Effect Estimates from Routine Health Data. So systematic review and meta-analysis. This was a trial specifically designed to help answer the question associated with comparing the ascertainment methods of traditional means with clinical endpoint adjudication. Can we do the exact same thing with routine health data sources and come up with similar conclusions with our results? The main objective of our paper was that it was a systematic review and meta-analysis. And we wanted to assess observational studies that compared death and cardiovascular events in randomized controlled trials through the two ascertainment forms that I've sort of been mentioning. So number one being the traditional method, which is clinical endpoint committee adjudication, versus number two, this new innovative routine health data source as a means for data ascertainment. So we conducted a systematic literature search from papers between 1976 to August of 2020. And to be included in our analysis, we actually looked at papers that had a minimum linkage threshold of 30%. So what is a linkage threshold? It's the ability to actually link a patient that's registered in a trial from their participant ID to the actual routine health data source. So for example, maybe that's their OHIP billing ID number. Sometimes that linkage is unsuccessful and we're unable to directly compare how this patient was followed in a routine health data source versus how they were followed in a traditional trial. And that can occur just through administrative challenges. We wanted a minimum linkage threshold of 30% between the number of participants in the original trial and the number of participants with corresponding routine health data identification. The primary outcomes of interest for our study were number one, the endpoint agreement rate, actually between clinical endpoint committees and routine health data, as well as their corresponding kappa values. And number two, the ratio of the randomized treatment effect, relative risks or hazard ratio for each endpoint, determined according to each source of outcome ascertainment. So here's our Prisma diagram for how we were able to distill approximately 4,000 papers down to the papers of interest, which became 9 in total. And here's a quick summary of some of our results. So there were 9 studies found comparing outcome ascertainment within routine health data versus clinical endpoint committee adjudication. We actually found that there was a very high degree of agreement between inter-rater reliability between clinical endpoint committees and routine health data outcome determination. So here are some specific numbers, but I encourage you to look at our published paper in CIRC quality outcomes, where we actually have the comprehensive tables. So all-cause mortality had an agreement rate of 98.4 to 100% with a kappa value of 0.95 to 1.0. And cardiovascular mortality had a agreement percentage of 97.8 to 99.9% with a kappa value ranging from 0.66 to 0.99. Here's a forest plot outlining the ratio of hazard ratios comparing clinical endpoint adjudication to routine health data as means of data ascertainment. I'll direct your attention to the left, which actually shows the outcomes. So all-cause mortality down to stroke. The number of studies that we were able to gather for each of these outcomes, and then the actual ratio of hazard ratio. So this is a metric that compares what the hazard ratio is in the traditional method of data ascertainment, what is it in the routine health data method of ascertainment, and whether or not there is a similarity, which would represent a ratio being close to 1.0. And on the right, lastly, is your respective confidence intervals. So we're able to see in a very illustrative way here that there's little difference in randomized treatment effect derived from your clinical endpoint adjudication committees versus your routine health data method of ascertainment. This is most noticeable in the hard outcomes of all-cause mortality and cardiovascular mortality. We were able to see pooled ratio of hazard ratios ranging from 0.93 for cardiovascular mortality to about 1.27 for outcomes such as stroke. It's important to note that a lot of these papers had what we would call harder outcomes in their studies. This includes all-cause mortality, major adverse cardiovascular events, and stroke. And there was less analysis done on what I would call softer or subjective outcomes, including significance of bleed or treatment side effects to a drug, for example. So based off of these results, in conclusion, we were able to actually say that clinical outcome ascertainment using routine health data displayed high levels of agreement with traditional clinical endpoint committee adjudication. Secondly, treatment effects determined by routine health data versus clinical endpoint adjudication were similar. So taken together, our paper here provides good support for the use of routine health data for future clinical trials. And further studies we would recommend are needed to rigorously assess routine health data and its role within randomized controlled trial data collection overall. I'd like to thank the course team for allowing me to present this information today. Again, you can see our paper that's published in full in Circ Quality Outcomes. And if there's any feedback or questions that you have for myself or my supervising physician, Dr. Jacob Udell, please feel free to email us via the corresponding email messaging platform affiliated with the actual published article. Thank you so much for your time.